Hello, I'm Larry Levitt from KFF. Welcome to the latest episode of the Health Wonk Shop. Roughly once a month, we dive into timely and complex health policy topics with experts from a variety of perspectives. The overturning of Roe v. Wade by the Supreme Court has renewed interest in medication abortion, which now makes up over half of all abortions in the US. Medication abortion can be done at home. It does not necessarily require an in-person visit with a clinician, which was quite important early on in the pandemic and may take on greater significance now that states can and are banning abortions. Yet our polling shows that most women between the ages of 18 and 49 had not even heard of medication abortion as of a few months ago. We're joined today by an impressive group of experts to discuss all of this. Dan Grossman is a physician and director of Advancing New Standards in Reproductive Health at UCSF. Jamila Parrott is also a physician and president and CEO of Physicians for Reproductive Health. Lori Sobel is Associate Director of Women's Health Policy here at KFF, and Francine Coiteau is co-founder and co-director of Plan C Pills. If you have questions, submit them at any time through the Q&A button in Zoom. We'll get to as many of them as we can. Also note that this session is being recorded and an archived version should be available later today. Let's talk about some basics first. And Dan, I'll start with you. Really basic. What is a medication abortion and when and how can it be used?
Well, thanks so much for inviting me to be a part of this. So the FDA-approved regimen for medication abortion involves two medications, mifepristone followed by misoprostol. Mifepristone is what's called a selective progesterone receptor modulator. It essentially binds to the progesterone receptor more strongly than progesterone. Progesterone is really important to help maintain an early pregnancy and keep the lining of the uterus thick. By blocking that effect, it kind of makes the lining thin and the pregnancy starts to separate from the lining of the uterus. The second medication, misoprostol, is a prostaglandin that starts to open the cervix and cause uterine contractions and essentially expel the pregnancy. So the regimen that is described in the FDA-approved labeling involves taking one pill of mifepristone, then 24 to 48 hours later taking 4 pills of the misoprostol, and they're taken buccally, kind of in the cheek pouch between the gums and the cheek, and allowed to dissolve there for 30 minutes and then swallowed. The FDA has approved this regimen up through 10 weeks. There's a lot of evidence about its use through 11 weeks and even later. The regimen starts to change a little bit after that. Misoprostol can also be used by itself for medication abortion, and it's also effective. The clinical studies that have looked at this show that it's somewhere maybe between 80 to 85% effective, but we also have evidence from settings where people are using misoprostol on their own through self-managed abortion that suggests it may have a very high efficacy rate, even as high as 98 or 99%. The regimen for misoprostol involves taking 4 pills, either under the tongue or placed vaginally, repeated every 3 hours, generally for 3 doses, but it can be continued after that until the pregnancy is expelled. So that's a quick overview of the medications.
Perfect summary. Jamila, let me turn to you and talk about when a patient uses medication abortion. What does she experience, and how is this different? How is that experience different from a surgical abortion?
So the biggest difference is where the abortion takes place. When we look at medication abortion as compared to, sometimes it's called surgical abortion or procedural abortion, some people call it in-clinic abortion. It's where the pregnancy expels. If you're having an in-clinic abortion or procedural abortion, then that occurs in your provider's office, right? Sometimes it's done in a hospital or an outpatient clinic. The medication abortion, the process actually happens at home. So the individual or wherever they are, not necessarily in front of the provider, right? But the pregnancy passes at home, and each person is really different. It depends a lot on what your experiences are like with your period. Right? So for folks who have really heavy periods, lots of cramping, oftentimes they describe this as similar to a bad period, or if they've had a miscarriage before, this feels really similar to that for folks who are using medication abortion. For other people, the bleeding and the cramping is more than you're used to. And so, but for almost everybody, things like over-the-counter medications, ibuprofen and Tylenol work well. for pain management, and then comfort measures, all the usual things that folks do if they have cramps during their period. So warm compresses, warm baths, that kind of thing, supportive services. One of the reasons why I think a lot of folks opt for medication abortion as opposed to procedural abortion is because they can control when it happens, right? And so deciding when to take that first pill, when to take the second set of pills. If you're using the FDA-approved regimen, then you can do all of the things you need to do. If you have other kids, you can put your kids to bed and have the process happen overnight so you can still care for your family. The bulk of the bleeding and cramping happens about 2 to 4 hours after you take the Misoprostol, and it usually lasts about 2 to 4 hours for most people. Now, there's some people it's going to be earlier or later. Some people the bleeding is going to be heavier or lighter, but on average, this is typically what we see.
And how about, I mean, Dan talked some about the effectiveness. How about the safety? What's the evidence of the safety of medication abortion, as well as surgical abortion?
Easy. That's the easiest question ever. Very, very safe. We have lots of evidence for both procedural abortion and medication abortion that say that they are both highly effective and very, very safe.
Great. That was easy and straightforward. Lori, let me turn to you. So clearly the big question now is how abortion bans in states will affect access to medication abortion. What are states already doing to ban medication abortion, to restrict or limit medication abortion, and how far can they go here?
Well, just stepping back for a minute, before the Dobbs decision, before the court overruled Roe v. Wade, many states had restrictions around abortion that included restrictions around medication abortion, like requiring ultrasounds, requiring counseling, requiring physicians to dispense medication abortion, and requiring patients to take the medication in the clinic, which obviously then ruled out any sort of telehealth visit if you have to be in the clinic to take the medication. Now, many of those same states that had those restrictions before the Dobbs decision have now enacted bans, which ban all abortions, which includes medication abortion. And so the question is, are they allowed to do that? And we don't know yet. The FDA has ruled that mifepristone regulates drugs and has found mifepristone to be a safe and effective drug. And so the question is, does the FDA get to regulate mifepristone and the states don't get to, or do the states have a role in regulating mifepristone because it's an abortion method or part of an abortion method? And there's already active litigation that we can talk about afterwards, but it's just this is now a setup between the FDA and the states and who gets to regulate mifepristone.
Well, I suspect as we're talking about the legal issues here, you're going to say a lot we don't know yet, but we'll see how the discussion goes. Francine, so Plan C is a resource for people looking to access medication abortion. Help people understand kind of what are the options for a pregnant person, both in states that have banned abortion and medication abortion, and in states that have not. Where can a patient turn to get a medication abortion? Oh.
Unmute, sorry.
Not the first time that's happened.
Thank you, Larry. Yeah, so we have a public health information campaign that helps people know where and how you can access abortion pills and how you can access the resources that are available for how to use them safely and effectively, has just been described. We now know that in all zip codes, no matter where you live, and despite these egregious laws that are being passed, you can have pills shipped to you and you can get the kind of clinical support you may want or need or not, depending on what you need. So the very important piece of the information is that it is still possible to get access to these safe pills. And like I say, up to you as to how much clinician support you might wish to have. There are lots of resources, and our guide, the Plan C guide to pills, is a state-by-state guide that once you say what state you're in, gives you access to all of the kinds of resources that exist in that particular state. And that is changing rapidly, but the bottom line is, in all these states, we know you can still access these pills. And because we really truly believe and know, and based on the kind of research that Dan has been doing and others that show how safe and effective these pills are, we really believe that getting information about knowing that this exists and helping people have access to the many resources, including, the M&A hotline, which will get you an opportunity to talk to the most knowledgeable clinicians on how to self-manage your abortion. We have a repro. We know that there's the repro legal help helpline through If, When, How that will help anybody who might be concerned about getting prosecuted or being criminally, or any worries that they may have about the legality. There are many, many resources out there, and our guide is the place to go for finding out what those resources are.
Thanks. And how, since the Supreme Court decision, have you, I'm guessing you've seen increased traffic to the website?
A huge amount of, we can barely believe it ourselves. Each time something's happened, starting with the Texas laws with SB 8 and SB 4, the traffic to our website just ballooned. And I can tell you that we basically have had almost 1 million hits to the website and specifically to the guide in the last 4 weeks. And then we are hearing from the providers that the aid access desk for help desk for aid access went from serving about the same number of people in an hour that they were serving in a week before, in terms of people reaching out to get information and get access. So it is ballooning. I think also you may have seen how many interviews. Everybody who's on this webinar has been interviewed, and the articles that are coming out that are letting people know that this is an option have been huge. And so I think we soon will be in a place where we won't have to be saying nobody knows about this option.
So Dan, we've been hearing these terms, and we've been using these terms about an at-home abortion, medication abortion, a self-managed abortion, whether or not there is clinician support in the process. Talk through a bit what the differences are between having a clinician support, not having a clinician support the medication abortion. There may be limitations in states that have banned abortion to have clinician support. What are the considerations that a patient should be thinking about there?
Well, I think what you may be getting at is, and what's sort of been alluded to, is that there's kind of a spectrum about what someone's experience with medication abortion can be like. That can vary from having a lot of clinician involvement to having no clinician involvement. And even, when a patient sees me and, where I provide care in San Francisco, we evaluate them often in person, but they're really managing the whole abortion experience on their own. It is a self-managed experience at home where they're deciding when to take the pills, they're following their symptoms, they're taking any additional medications that they need when they need them. They are kind of being alert for any signs of a potential, worrisome side effect that might need further evaluation. And that's the same with a self-managed abortion. So the difference is that people are evaluating themselves on their own for eligibility, sometimes with the involvement, sometimes they're obtaining the medications through an online telehealth service that does provide some help with the evaluation for eligibility, helping them potentially assess how far along they are in their pregnancy, screening for the other, very rare contraindications. But then people are, need to be informed about what are the potential side effects, what are the potential warning signs, and then how to access care. I guess I will say I mean, kind of relates to some of the questions too about how, the way we have been providing medication abortion in facilities has really changed, largely pushed by the COVID-19 pandemic. There's been, a lot of research about providing medication abortion using telehealth, where people are being screened for eligibility without an in-person visit, without routine use of ultrasound, or without routine use of other kinds of blood tests or other in-person evaluations. And we find that the majority of patients can be evaluated just through a telehealth evaluation, either over the telephone with a video visit or entering this information through an online portal. And that there's a great deal of published information now showing that that model of care is safe and effective. And in fact, the FDA has reviewed that evidence and essentially has said that telehealth is a safe and effective way to provide medication abortion. And based on that evidence, in December of last year, permanently removed the in-person dispensing requirement for mifepristone that was part of the risk evaluation and mitigation strategy, or REMS, for the drug.
And Jamila, I mean, I mentioned our polling at the beginning that, there's a real lack of knowledge about, even among women of reproductive age, about medication abortion. In your experience seeing patients, does that ring true? Are people seeing you looking to access an abortion, not understanding their options? And what are some of the equity considerations here in terms of how we reach more vulnerable communities?
Sure. One of the things I think is important for folks to understand is that I think that there are worries that folks can't manage their own abortion or should not be managing their care because of the way abortion is in this country is highly regulated. And it's important to understand that that regulation is not occurring because this is an unsafe medication, but instead because of political ideology and intentions, right? And so when folks see something that is highly regulated, then they often think that it must be unsafe. And that's why the government is stepping in. That is not true for medication abortion. And in fact, it is safer than most medications, many medications you can get over the counter. So that's the first piece of education it's important for folks to understand. The other thing, and why there is this big gap between rhetoric and reality and an information chasm around abortion, is because of the stigma around abortion care, right? And so we've seen that the anti-abortion rhetoric really feed that stigma, and it creates a lack of knowledge, a confusion for both patients and those seeking abortion care, but also healthcare providers who don't provide abortion care. So that confusion sometimes really spills over into the clinical care space when people just aren't sure what to expect, what we're going to do, what the medications are, what's going to happen with that process. The last thing I'll say in terms of contributing to confusion and lack of information around abortion access is that we have to connect it to the larger assaults against comprehensive sex education in our school systems, right? And so thinking about how we talk to young people about reproductive health, about their bodies, about abortion, should begin much earlier than when people present because they need an abortion, right? Or they're seeking abortion care. So understanding those connections are really critical. When we think about equity gaps and who is at greatest risk when we're talking about inequity, it's important to understand that structural and systemic inequity is really feeding these disparities, both in access and reproductive health outcomes. And it didn't begin or end with the Dobbs decision. We're talking about centuries of structural inequity. So for folks who are most likely to need access to abortion care for a myriad of reasons, and folks that are going to be most directly impacted by restriction on abortion care, the same communities, because these are structural issues. We're talking about communities of color, in particular, Black women and pregnant and birthing people, Indigenous folks, young people, those who are undocumented. These are the same folks who are least likely to be able to access abortion, certainly before the Dobbs decision, and especially now. And also to the point about accessing pills outside the formal medical system for folks who are self-managing, the same communities are at greatest risk for being criminalized for managing their care. care. So we can't talk about these things as separate. We have to talk about them as all together. It is important that folks have access to this medication or to managing their own care, whether it's abortion care or gender affirming care or whatever care is best for them in the way that they want, the way that fits with their life, that fits with their values. And we cannot not discuss the risk of criminalization for our communities, because folks who will be criminalized are more likely to look like me than many other folks. And we have to say that very clearly. So when we talk about the risks are not medical. We know this medication is safe, whether they're getting it from me or getting it online and managing their own care. The risk is a legal one.
Speaking of law, we've had a number of questions about how the FDA regulates these medications, and Dan got into this somewhat, and differences between the way the two medications are handled. Laura, can you just back up and talk a little bit about the history here? How did the FDA regulate these medications? Were there distinctions between mifepristone and misoprostol, and what has changed?
Sure. So mifepristone has what's called REMS, which Dan just alluded to, which are special rules that that the FDA uses to regulate what are considered more dangerous drugs. As everyone has stated, this is kind of not very fitting for this drug, but because of the politics, this has been in place for a long time, since the FDA first approved mifepristone in 2000. Most recently, they have lifted some of the requirements. So up until December of 2021, and with a break during the pandemic of enforcement, the drug was required to be dispensed in person. And in December of 2021, the FDA, looking at many studies and the evidence, concluded that was no longer needed and lifted that requirement. There are still other requirements that are specific to mifepristone. The clinicians that dispense it and prescribe it need to be certified by the manufacturers. Pharmacies are now allowed to also dispense it, but again, need to be certified. So it's still not just a drug that can be easily dispensed without providers going through additional hoops, but the in-person dispensing has been lifted. Misoprostol has been approved by the FDA, but doesn't have the REMS associated with it.
One thing?
Yeah, please.
No, just because that was a great summary. And it is true that the FDA issued its determination in December of last year that they were changing the REMS, adding pharmacy certification, and removing the in-person dispensing requirement. But that's not yet been implemented. So there is some process that is underway where the drug companies, both Danco and GenBioPro, are working with FDA to come up with a system to implement this new REMS. And so it remains to be seen exactly how burdensome this will be, how burdensome it will be for pharmacies to get certified. I mean, as we talked about, this is an incredibly safe and simple to prescribe and dispense medication. There's no reason for any kind of certification for pharmacist or pharmacy. So it remains to be seen whether this new modified REMS will be implemented in a way that potentially imposes different barriers, or if it's implemented in a way that could try to eliminate these barriers. But this announcement of the implementation of the new REMS could be an opportunity for the FDA to really clarify again how safe and effective this treatment regimen is.
And Dan, do you see any prospect of eliminating REMS or relaxing it substantially?
Again, I do think it's a possibility that the way that the FDA chooses to implement this modified REMS could be done in a way that really streamlines the process. Essentially, could make certification of pharmacies just pharmacy ordering the medication. It could be, already the prescriber agreement form is a self-certification process. They could just say, you have this on file, and when you prescribe it, you're essentially saying that you have completed that self-certification process. So it could be done in a way that really eliminates some of these obstacles. In terms of eliminating the REMS in the short term, You know, I think that would be an evidence-based decision because there is no benefit of the remaining components of the REMS. There's no benefit to patient safety. But that said, the FDA just kind of went through this whole review of the evidence last December and decided to keep certain elements of the REMS. So I don't know, obviously the situation has changed, and I think it's certainly reasonable to be asking the FDA and the current administration to permanently to just remove the REMS because there is no benefit to it.
And just if I could jump in 1 second, because I love that, because there is no medical or scientific benefit. And so what the ask is not of the FDA to remove the REMS. The ask is for the FDA to follow the science and the medical evidence, the way that it is followed with every other medication that they evaluate. And what we know is that if that occurs, it will ultimately lead to the removal of the REMS because the science and the medicine supports that.
And Jamila, let me ask you, we have a lot of questions. We're not going to get to all of them, but I'll get to as many as we can. So one was in terms of who eligible, who can get access to this medication. You talked about structural inequities. We had a question about patients who are underage. Do they qualify for medication abortion? Can they get access to medication abortion? What are the privacy considerations, parental consent?
So it's really state dependent, right? Because the restrictions around medication abortion in many states are similar to restrictions around abortion more broadly. And so state by state, you can see parental notification or consent requirements, and that really does shape the experience of the young person that's trying to access these medications. For whether it's an in-clinic abortion or a medication abortion, for a young person trying to navigate parental consent laws, judicial bypass, trying to get time off from school, trying to maintain their privacy, it can be a really burdensome process, right? And so understanding that the barriers are going to be even higher for young people. What we do know is that most young people who are seeking abortion care have a trusted adult in their life that they are talking to about their decision. That is not true for every single young person. And our hope is that we can build supports around our young people so that they can navigate this process with success. But it's not easy to say, yes, young people can access it. No, young people can't access it because the restrictions around abortion are so state specific. What we do know is that young people are intelligent, equipped, and able to make decisions about abortion for themselves, with and without parental involvement, and with the support of many people in their lives. So this is not a decision for anyone, whether it's a young person or not, that occurs in isolation. And so there are supports in our lives. We have communities that we live in that provide those supports. That's the same for young people. And we want to make sure that that continues and they're not excluded from being able to have access to medication abortion or any other abortion because we believe that they aren't mature enough to make this decision. That doesn't show in the medical evidence. They can read the labels, they can follow instructions, they can self-evaluate, and we must trust them to do that as clinicians.
Yeah, Francine.
Yes, thank you. I'd like to add to that. There's evidence now and published evidence. There's a really great article that just came out from Abigail Eiken's team at University of Texas, Austin, Texas, that interviewed patients who had used aid access and to find out from the patient perspective what was it that they liked or didn't like and what was their experience. And we have growing numbers of evidence of the fact that all types of people, many different groups of people are accessing these drugs through these alternative, you can call them alternative means of access. The opportunity to self-manage and to really have the agency in the hands of the person who needs it is what we're seeing here. And that is a workaround, you could say, on all of these laws that have been and restrictions that have been put, as Jamila says, state by state. If you go by the laws, pretty much it's gotten very, very narrowly restricted. but the evidence of what's happening in terms of people who are looking to meet their needs and who are finding that neither the legislators or sometimes even the health professionals are not meeting their needs. They're going to these alternative methods, and in the tens of thousands. And young people of people of color, people the people who are normally very much potentially at risk. Are the ones who are having to go to these alternative ways of getting care. I just want to add one other thing about access is one of the things that has been made very, very clear by the various providers and networks of these providers is that income or our ability to pay is not one of the barriers, because these providers have made the commitment to have a sliding scale and make it be at cost. At whatever you can afford, and that's being implemented across. Now, clearly, there are many other barriers, and we're hearing exactly what Jamila said. It's the fear of these unjust laws that are potentially criminalizing the people who are at already most risk. That is the biggest issue. That is the biggest issue around access. It's no longer health. It really is around these unjust laws that are criminalizing people for self-managing their care.
So we had several questions about privacy considerations, particularly connected with potential criminalization. What are some, and Francine, maybe I'll start with you. What are some ways that a patient can protect her privacy when seeking information about medication abortion, or in fact seeking medication abortion through mail, through some of the mechanisms you talked about?
Yes, I see this as the latest front of trying to again stop access or take agency away or scare people, which is to this whole digital privacy and the fact that literally you could be people could take your phones and use your phones or use your internet history to try to criminalize you. So there's a whole, many of us have had to regroup and spend a lot of time and care into trying to reduce the opportunities for criminalization via online provision. So there's a lot of attention being paid on how to do that. I do also believe that this is one of the ways in which it's a little bit like SB 8 in my mind. It's scaring people into there they tried to scare everybody who was aiding and abetting. Here now, the biggest thing we're finding with Plan C is that the right is attacking us online and on the digital platform. We're finding that one of our biggest challenges is now websites that are popping up that look like ours. We sometimes have a hard time realizing they're not ours. That's how good they are. And yet they're like these pregnancy centers that are, fake pregnancy centers that are trying to grab people away. So yes, there's a lot of concern around digital. We're still working our way around, as is everybody, trying to figure out how to protect the patients. As all of these providers, every provider that's working on abortion for years has had to be careful with all the HIPAA laws and the to protect the patients, and this is just now rising in terms of concern.
Before you, can I ask one thing to that?
Please.
I think it's important that when we think about criminalization, when we talk about criminalization, although this is about the Dobbs case and medication abortion post-Roe, it's important to understand that this is one act, but where the criminalization is tied to the individual and not necessarily to the act. Abortion is the newest way that communities who have been historically criminalized will continue to be criminalized. And so when we think about ways to address, to attack, to push back against criminalization of our communities, we need to do it not from an issue-specific standpoint, but from a structural and systemic standpoint to understand that it is the individual who is targeted for their behavior because of their identities that are marginalized, right? That's a bigger picture view of criminalization. But if we only focus on the criminalization of self-managed abortion, we miss the fact that communities are going to continue to be criminalized in all kinds of health decision-making. We saw this during COVID pandemic, right? Communities being criminalized for being vaccinated or not being vaccinated, wearing masks or not wearing masks. It isn't the act, it is the individual, and that we cannot lose sight of that.
Thank you. So we've had a lot of questions about this issue of state versus federal authority here, particularly around this question of medication abortion and whether states can effectively overrule an FDA decision that a drug is safe and effective and can be available. Lori, can you talk a little bit about this? What is the legal landscape here? Talk a little bit about the case in Mississippi, challenging the ban there.
Sure. So we have exactly one case that has already been decided, and it was only decided by a district court. This is a case from 2014 from Massachusetts, in which Massachusetts tried to ban a specific opioid that the FDA had approved. And that district court judge said, no, the FDA has approved this as a safe and effective drug. Massachusetts, you're not allowed to do that. It was never appealed. So that's the only case that's directly sort of on point. The active case that's going on right now in Mississippi is Gen Biopro v. Dobbs, because it's in Mississippi. And in that case, the manufacturer was challenging Mississippi's rules at the time. So this was filed in October of 2020. And Mississippi had specific regulations around abortion that also applied to medication abortion. So a 24-hour waiting period, counseling, ultrasounds, and physician dispensing in the clinic. And Gen Biopro's claim was, well, this is beyond what the FDA has ruled as required for this drug, and the FDA gets to regulate drugs. And Mississippi, you don't get to layer on top additional regulations. The status of the case right now is that the briefs are being refiled in light of the fact that Mississippi has now a complete ban. Their trigger law has gone into effect on all abortions, including medication abortion. So we have to just wait and see what happens with that case, and likely it will be appealed. And we don't know yet if the FDA will directly try and shut down states that are banning medication abortion or have additional regulations around medication abortion beyond what the FDA has said is required. We know that the Biden administration has come out strongly stating that they will make medication abortion accessible. We know the Attorney General has also stated that they intend to make medication abortion available in all states, and the FDA rules preempt state rules, but we don't have a court decision on point yet.
And to be clear, that there's some lack of clarity around what it means to make medication abortion available in a state that has banned abortion, right?
Right. We don't know exactly what the Biden administration plans to do to make that available. The closest thing that we have on point is that Attorney General Merrick Garland has stated that he believes the FDA is the rule in the whole country, and the FDA rules preempt state laws. That's what his office has stated. So again, we don't know exactly what that means from the Biden administration. It was from an executive order to make medication abortion available throughout the country, and we don't know exactly how that will play out.
Can I add just a tiny bit?
Yeah, please.
I mean, I think there have also been some questions about the potential use of telehealth medication abortion across state lines, including to serve patients who are living in states with bans. I mean, Lori, please correct me if I'm wrong, but I mean, that's definitely complicated. Generally, telemedicine is viewed as occurring where the patient is, meaning that the clinician needs to be licensed in the state where the patient is, and the service needs to follow the laws and regulations of the jurisdiction where the patient is. And so it would be, challenging to be able to legally provide medication abortion using telehealth across state lines to states that have essentially banned abortion or banned medication abortion. That said, a number of states with protective legislation have passed new legislation, or governors have issued executive orders to protect providers from civil liability, criminal liability, protecting their licenses. So far, the only state that I'm aware of that is moving toward doing something that would specifically protect telehealth across state lines is Massachusetts. I don't believe that law has yet been signed by the governor, but it's been passed by both chambers, and so it remains to be seen how that will actually work and whether other states may put into effect similar policies. But certainly there's a lot of interest among providers to be able to do that, and we certainly have the technology to be able to provide telehealth safely across state borders, but we are limited by these laws.
And we, I mean, during the pandemic, there was a lot of flexibility provided to allow telehealth across state lines more broadly.
Right, so what we're seeing though is like the state versus state in addition to the state versus the federal. So the states that want to ban abortion want to ban it beyond their borders, and the states that are seeking to protect abortion want to be able to have people from other states access abortion as easily as possible, whether traveling to their state or via telehealth. So it's the state versus state and the state versus the federal is kind of how this is lining up.
And Jamila, I mean, this issue of kind of across state lines traveling to obtain an abortion. How do we think about this in terms of traveling for a surgical or procedural abortion versus traveling for a medication abortion? I mean, does it open up greater possibilities, particularly for people earlier in their pregnancy?
It opens up greater possibilities for people who already have possibilities, right? So thinking about those who are resourced already are likely have already been traveling. It's important that we understand that for even prior to Dobbs, prior to Roe in 1973, people who had money, who had resources, who had connections, had safe abortions, right? And so that is not going to change now. And so this piecemeal approach to abortion access is a solution for no one. One, it is a very slippery slope. No one is safe. I think what we saw happening with SB8 in Texas was a response that allowed people to say, well, that's just Texas, right? We can write them off, or that's just Mississippi, not understanding that this was intended to sweep the country. And so there is no red state versus blue state, or protection here or protection there. If this right is at risk for anyone in any state, the right is at risk for every single one of us. And that's the approach that we have to take. So the idea that folks will be able to travel from Mississippi to Massachusetts to get their abortion, or Mississippi to Louisiana or North Carolina, or even in DC where I live, that somebody would be able to travel from east of the river to downtown DC to get an abortion, have time off, have childcare, have resources. So it isn't the geographical distance that makes the biggest difference. We're talking about a safety net of resources, wraparound services that our communities need to be able to access this care. We're happy that some states are working to codify abortion access in their law. So I'm not in their constitution. So I'm not saying people should not be doing that and we shouldn't be passing proactive legislation. But my response is yes, and then what? What do we do for folks who cannot travel, who cannot move across state lines, for folks who are in Texas, Arizona, New Mexico now, which has in-state checkpoints where people can't leave the state now because they are undocumented? How are we advocating for those folks?
And Dan, talk about, and we've had several questions about this, and Lori touched on it a little bit, how this is affecting conditions broader than abortion. How is this affecting, are these drugs used for other health conditions? And are we seeing access problems? Are we seeing access problems for other drugs that are believed to be medication, to allow for medication abortion, like methotrexate?
Yeah, I think it's a really good point. I mean, these same medications, mifepristone and misoprostol, essentially the same regimens, are also the most effective treatment for treatment of miscarriage. And so by make it difficult to access these medications for abortion care, it's also can be difficult to access for miscarriage. And certainly we've heard of cases where pharmacists have been, refused to dispense misoprostol, for example, for miscarriage or for other reasons, because they're concerned that it's being used for abortion. Misoprostol is also used for a variety of situations when there's a need to open up the cervix or soften the cervix before a procedure, before inserting an IUD, for example. And we've heard of cases where patients have been unable to get it from the pharmacy because of this concern about abortion. Similarly for methotrexate. Methotrexate isn't currently a regimen that it's not used for abortion generally in the US now, but it has been studied and is an effective regimen that can be used for abortion. And so we're hearing of that people are facing challenges accessing this medication when they're using it for other reasons. So it's really very concerning and kind of, I mean, to get to Jamila's point also, I mean, it's like policing anybody with the capacity for pregnancy, who needs these medications for their healthcare.
Well, we're unfortunately coming to the end of our time. I think we could do this for quite a while, but I want to give each of you just kind of quickly leave us with one one message you want people to leave the discussion with. And Francine, I'll start with you.
Yes, thank you. I'd like to just build on what Dan said, what Jamila said. It's not science that is holding us back. It's not the technology that's holding us back. To be patient-centered, it's really these unjust laws. And there are a lot of people stepping up now to realize that maybe call it civil disobedience, call it conscientious provision, call it what can I do given this horrible situation. There are lots of people stepping forward to want to see what we can do to take advantage of this new technology that, could we, do we really demand that somebody from Texas fly all the way to California when if they choose, they could have it shipped to them and then they could self-manage at home without the inconvenience of all that? Why are we demanding that? Is it because of laws? And are these laws just, and can we push against them? So that's where I would end.
Thank you. And Lori?
I would just say stay tuned on the legal issues. I think we have a lot of litigation ahead of us, and probably will end up back at the Supreme Court in terms of how states are allowed to regulate drugs versus the FDA, and whether this will bleed into other issues like gender affirming care and other things that are also politicized. We'll have to wait and see, but my guess would be yes.
And Dan?
Yeah, I guess one thing I might add, and there were a couple of questions about this, about, should all abortions be medication abortion, or, when is procedural abortion preferred? And just want to highlight, I mean, this is great, timely panel, but just to say what I think all of us feel is that medication abortion is an amazing technology. It is not the solution to this abortion access crisis that we are facing, and undermining people's basic human rights. It can help to mitigate some of the harm, but it's not solving this problem. And there are people who have a strong preference for a procedural abortion, who want to be sedated, who are maybe past 10 or 11 weeks, and again, would prefer to have a procedural abortion, or for any number of reasons. And so we really, we need to have access to these life-saving pills. And we also really need access to communities in our clinics so that people can access procedural care when they need it.
Thanks. And Jamila, you get the last word.
Sure. So two quick things. One, what my last words are as an individual, right? I'm an OBGYN and an abortion provider, but I'm an advocate and an activist and an organizer at heart. And so as we're thinking about solutions for a way forward in this post-Roe America, We say that as if folks weren't living post-Roe in many parts of the country and in many communities. But as we're thinking about what our solutions are, my ask is that we design systems that really benefit those who are at the margins of care. This is like Black feminist organizing 101, right? If you design a system that benefits those at the margins, everyone inside will benefit, right? So that's the first thing. When you're thinking about solutions, think about those folks that are on the outside, not those that are proximal to power. And the second piece is from my provider hat, is to really talk about what our unique value add as healthcare providers in this moment. And I can tell you what it's not. It's not to collude and participate in the criminalization of our communities. There is no law, there's no mandatory reporting law about if you suspect somebody has self-managed their abortion. There is no reason ever to call the police on your patients, especially though, because you think that they have managed their own care. So understand, and there is no mandate to turn over records to the police and your hospital systems. Protect your patients' privacy. We have an opportunity as healthcare providers to stand in the gap and an obligation to refuse to participate in criminalization of those that we care for.
Well, thanks to all of you for a tremendous discussion that is just the beginning, hardly the end. And thanks to all of you who joined us in the audience as well, and look later, likely later today for an archived recording of this. Thanks again.